and thank you for joining me today, wherever you are in the world, for my presentation entitled Unique Opportunities for Utilizing Specialty Contact Lenses. My name is Kelsy Steele, and I'm joining you from Columbus, Ohio, in the United States, where I work at the Ohio State University College of Optometry as a clinical instructor and a researcher. I have no relevant disclosures for today's presentation. So if you're joining us for class, you are probably pretty familiar and comfortable with most of the traditional uses for specialty contact lenses, including things like refractive error management, just run-of-the-mill spherical contact lenses, all the way to compound astigmats, also for our irregular astigmatism patients. So maybe patients with corneal irregularity from keratoconus or pellucid marginal degeneration, or even patients that have post-LASIK ectasia. Finally, for myopia control, you might use orthokeratology or multifocal contact lenses in your practice for myopia control. If you don't feel comfortable with those topics, just stay tuned. Class will have plenty of great presentations covering a variety of topics, many of these included here. Today, I'm going to flip it around a little bit. I won't really be covering any of those. We'll be talking about some of the more unique and non-traditional utilizations for specialty contact lenses. We'll spend a lot of the time talking about colored contacts. We'll talk a little bit about tinted as well as prosthetic and occlusion contact lenses. We'll talk a little bit about the addition of prism in specialty lenses, as well as the appropriateness in a patient with nystagmus. We'll talk a little bit about ocular surface conditions and what lenses we might utilize for those treatments, such as dry eye or epithelial defects. And I'll also throw in some cases here and there for patients that I have seen where I've used some of these different types of lenses for those patients. So to start off, we're going to talk about colored contact lenses. We have a lot of options in this realm, so you might be familiar with some of the cosmetic options that are commercially available. These come from some of the larger manufacturers that you might use on a daily basis, and they're readily available. Patients might use them just for cosmesis to change the color of their eyes from blue to green. They might use them for costumes, like if they do cosplay or around Halloween. But these are the ones you might be more familiar with. There are some other options, such as hand-painted and digitally printed contacts. We'll talk a little bit about tinted as well as pupil occlusion and when that might be necessary for your patient. So to start off, cosmetic contact lenses, like I said, are those commercially available lenses. These don't really have any customization, so you kind of get what you get as far as the size and the color and the opening in the middle of the lens for your pupil. Some of these will come in spherical powers. There used to be some that came in toric. I'm not sure if there are some in other parts of the world that are available. And these are going to vary as far as their replacement schedule. Nice thing about these is they're a little bit more affordable. They're very reproducible, so they're always going to look the same. And some of these are going to have more frequent replacement schedules compared to some of our more customized versions. They even have some of these in a daily disposable. So if you have a patient that is just a sometimes wearer, that might be an appropriate option for them. As well as if you have a patient who's had problems with contact lenses in the past as far as inflammatory or infectious conditions, they might do better with a more frequent replacement lens. So who would we use this with? Some of the indications besides just cosmetic would be scarring of either the cornea or the iris. So if you have one that's a little bit more peripheral and maybe not so large and dense, this might be an appropriate option. As well as if you have defects on the iris. So the picture here is somebody who has an irregular pupil as well as iridodialysis near the limbus. So that patient might do just fine with a commercially available contact lens that's colored to hide some of this defect. If you have a patient with a coloboma, maybe they have a little bit of a defect at 6 o'clock, these commercially available lenses might be appropriate for them. And then, like I said, some scarring of the cornea or the iris that may not be super apparent or super dense. Moving on to hand painted, this is going to be one of the most customizable options for our patients. We can choose the diameter of the iris. We can choose where the iris is centered. We can choose the pupil diameter and if it's clear or if it's occluded. And then we can choose the backing on the lens. So do you need a white or black iris backing? Will depend on the patient's under eye color. So what is their fellow eye iris color, as well as the nature of the defect that you're trying to cover up. So is it very, very dense? Then we might have to have a different backing. You can also choose the base curve that you want, as well as the overall diameter. The process for fitting this is going to be pretty detailed as far as the color matching. Some of the labs that you might work with want a color photo, and they might have requirements as far as the lighting conditions and have you take multiple photos. They might ask for photos outdoors and indoors with lower lighting conditions, with fluorescent lighting conditions. Some are even as specific as what kind of background color they want or what color they want the patient to wear. This is just going to ensure that they are the most successful as far as matching their prosthetic lens to the fellow eye. With these lenses, the color does fade over time, so you might have to talk to your patient to expect that. Generally, these are going to be annually replaced because that does happen over time. And this is most appropriate for lighter colored eyes or very specifically colored eyes. So if you have someone who's gray, blue, or green, or somebody who has really specific limbal rings or iris flecks that are very unique to them that they want to match perfectly, that would be when this is the most appropriate option. It is the most expensive option typically, and it is the one that takes a lot more time and expertise to get correct. As far as our indications for these, some of them are similar across the board, so any kind of scarring, patients might want some kind of colored lens to cover that up. With this one, you can have a fixed or irregular pupil that's either covered up completely or masked. If they have corneal scarring or iris scarring, maybe they have iridodialysis or a coloboma like I talked about, and patients who have aniridia. Another unique option for this is in your strabismic patients. So if you look at the picture on the bottom, you'll see that that iris is offset on the contact lens. And so the underlying color is white, and then they're able to add vascular detail to match the fellow eye, and then they offset the iris and the pupil. And so the patient looks like they're staring straight ahead in fixation when they have a strabismus. So this is an option for patients like that. Patients who have double vision or very heavy light sensitivity may do well with these as well, and they would typically prefer a blackout pupil or an occluded pupil if they're very light sensitive or if they have diplopia, double vision that just does not go away. Another great option is digitally printed. So these parameter options are also customizable, but a little less so than the hand-painted version. So you can typically choose what iris diameter you want, your pupil diameter, and just like with the hand painted, is it clear or is it occluded? Your lens power can sometimes be added to these too, depending on what lab you go with. They might even have astigmatic options. You can choose the base curve, the overall diameter of the lens, and then the lens backing. Again, what are you trying to cover up? And what is the underlying iris color that will necessitate what backing you choose. These are highly reproducible. So unlike the hand-painted ones, these are just printed the same every time. So they do look the same over time if you were going to repeat this for a patient. They have some layering options for some of them. So they're a little bit more nuanced than just the commercially available printed ones because you have layering. Let's say you have someone who has a hazel eye. And you can layer a green over a brown or a brown over a green, and those will come out looking a little bit different. You also have the options for limbal rings if you're trying to match a fellow eye that has that, or peripupillary rings that might be very specific to that patient. So there is a little bit more customization with this one as compared to just the commercially available ones. This color doesn't typically fade over time. This is really appropriate for darker eyes because it's not always necessary to get the more expensive and detailed hand-painted version for somebody who just has a solid brown iris that doesn't have a lot of other colorations or details to it. These will sometimes have more frequent replacement depending on where you get them from. They might be quarterly or semi-annually, but some of these might be annually, just like the hand-painted versions are too. So you want to check with your lab to see what their recommendation is for lens replacement. As far as the indications, very similar to the hand-painted ones. Like I said, the big difference is that hand-painted is normally most appropriate for your light irises, and you can normally get away with the digital printed with a brown iris, but it really just depends on the nature of what you're trying to mask on the eye. So our first case, I'm going to talk about PD. He was my little 8-year-old guy who came in, no real pertinent medical history. He was referred from ophthalmology for a scleral shell. So there was a little bit of miscommunication when the appointment was made, and the front desk thought he was coming in for a scleral. We don't do scleral shells, but I still saw him just to see what was going on. Was there something that we could maybe help him with? Like I said, medical history was unremarkable. Ocular history was significant for an ocular injury when he was 1 year old. I do have a picture of what that looks like. It's not great, but it's a picture so you can kind of get an idea of what we were working with. He didn't have any current correction. In the fellow unaffected eye, he was 20/20. In the scarred eye, he was light perception. The goals for him and his mother who came with him were cosmesis and self-esteem. So when we were talking a little bit about him and his eye, Mom was saying he's very shy. He doesn't like to meet new kids. He was starting a new school in the fall, and he was very apprehensive. You know, little kids, they say what's on their mind. So, hey, what's wrong with your eye? What happened to your eye? He was very self-conscious about that. And so he really just wanted something so that he could look like the rest of the kids and just feel a little bit more normal. In addition, he was hoping to address some of the glare and light sensitivity that he was having. He still had some inflammation that would come up here and there that would cause some light sensitivity. So they were hoping to address that as well. Like I said, he was sent over for a scleral shell. Some of the notes that we received said that the eye appeared a little bit tisical, meaning that the eye had shrunken in size, which will sometimes happen for patients who have had an ocular injury or ocular surgery. I didn't really agree with that. I just thought he had a little bit of ptosis. So if he was truly tisical, then a scleral shell would have been more appropriate. But I thought the eyes seemed about similar size. So we had a discussion, and Mom was on board, and so was he, with trying to do a colored contact lens. And so we did a fitting. And we used some clear diagnostic lenses to see how they fit and how they move and center. And we decided to order a MedCorp Cantor prosthetic lens with an 8.6 base curve and 14.5 diameter. Like I said, we decided on that just based on clear diagnostic fitting from lenses that we had. Due to the light sensitivity and because of the nature of the scarring, we did a blackout pupil for him in a 4.5 millimeter diameter in just a plain brown color. So we took a few measurements, bright lights, ambient light, dark, to kind of get an average of his pupil size to match it the best we could when deciding on the diameter. And no power because we were doing a blackout pupil. And so this picture is a not great picture of his cornea. So you can see that he has sutures and scarring going diagonally across pretty much the entire cornea. So it's very opacified. You really can't get a good view inside. And that is why he's very self-conscious. And so we dispensed the lens to him, and he was big, huge smile, so excited, kept checking himself out in the mirror, and he was thrilled with the outcome. It fit well, it centered well, it was comfortable for him, and he ended up wearing it pretty much full time. So the second patient here, a really nice gentleman, WC, a 69-year-old black male patient of mine. Medical history is relevant for just high blood pressure and diabetes, not really relevant to his eyes right now, as far as what we're talking about. Ocular history, very similar to our previous patient. He had an injury in childhood. We don't really know the nature of the history. He doesn't actually know it either, but you can see from this picture that he has pretty diffuse corneal scarring. If you look at his eyelid margin, you'll also see that that's irregular. So he has some scarring and irregularity to the eyelid margin that causes some entropion. And so his eyelashes point inwards and they rough up his corneal surface. So not only is he light perception in this eye, he also is really irritated and sensitive and kind of gritty feeling because of that eyelash, the clump of eyelashes always rubbing on his front surface. We generally epilate lashes for him every 3 to 6 months. He just comes in and we pluck him out and send him on his way. His current correction was just glasses. He was doing well with those. His left eye, 20/20, and the lenses were just balanced, so they looked the same optically to somebody looking at his glasses. His goals, similar to the last kiddo, were he was just interested in some cosmesis. He wanted to look fancy if he had a night out or going to a special event. He wasn't planning on wearing them all the time, but he just wanted that option for special events. Additionally, he was interested in some added corneal protection because it acts almost as a bandage lens from that entropion in between when we see him for epilation. And so we use the Orion BioColors lenses for him. This is one of those printed options where you can layer the lenses if need be. For him, we just chose a simple brown color, 8-1 base curve, 15-0 diameter, based on how the clear diagnostic lens fit on his eye. We chose a blackout pupil, again, because he was light perception and because his pupil is opacified anyway, and no power in that lens. So he was really pleased. If you kind of look back and forth, you'll see the before and the after, and it was a very good color match for his fellow eye, and he was very happy with the result. So moving on to the transparent tinted option. So this option can change the appearance to us, to somebody's iris, but it also is going to change the patient's perception of the outside world. This is going to be reproducible, usually, just like the printed ones that we talked about. You have some customization as far as the iris diameter. It's not necessarily supposed to copy the iris, but it's just a transparent tint that you can size depending on the size of the iris. You can choose to tint the pupil or not tint the pupil, and then you have some variability as far as the size of the tint. It's a little less customized, but it's a lot more affordable. So depending on what your goals are, this may be an appropriate option for your patients. Similarly to the other ones, you can start off with a clear diagnostic fitting to get your base curve and get your OAD. You can either send your lenses to the lab to tint. So you choose your lens, you try it on, and you just send a trial to the lab and they will tint it for you. You could also do an in-office tint. So that picture to the side is one option as far as an in-office kit, and that's actually what we have at OSU. So we do both options depending on what we're fitting and why. But this is a nice option if you have a patient who isn't quite sure what kind of saturation level they want. And so you can take a few diagnostic lenses, tint them for various amounts of time, and then the patient can try it on and see which one seems most comfortable. There's a little kind of recipe book that tells you what color you're trying to get and what saturation, how long you need to keep it in the dye. So there's a little timer in there too. It also has the little prints. So if you want to just do an iris ring and keep the pupil clear, you can do that. If you want the iris clear and just the pupil tinted, you can do that as well. So you have a lot of customization within reason for these lenses too. Why wouldn't you use them? So patients who are photophobic, we'll talk a little bit about a case where that's an example. Patients who maybe have migraines, oculocutaneous albinism, maybe a patient had a traumatic brain injury and they have post-concussive syndrome. Patients that have colored vision abnormalities may do well with a tinted lens. They're not really trying to change the appearance of their eye. They're trying to change how the world around them appears to them. And so that's an appropriate option for those patients. Also, you might see this for athletic performance. Just like hunters might be wearing like an amber tinted pair of glasses, they might prefer to have contact lenses. So we have some athletes that want specific tints, and we can do that for them with a soft contact lens. One thing to keep in mind is these lenses are generally less oxygen permeable because silicone hydrogel does not take up tint very well. So most of these are HEMA. So just keep that in mind if you have somebody that you're really concerned about the ocular the amounts of oxygen on the ocular surface, just keeping that in the back of your mind if you want to do this kind of thing for a patient. So maybe you have a patient that wants to do this, but you have no idea what tint to choose for them. I wish I had a chart where I could tell you this is the condition and this is the color, but it doesn't really work that way. It's very patient dependent. There are generally a few that the literature recommends just based on anecdotal evidence. But it's really a good idea to demo a few different filters for your patients. So if you're lucky like me at Ohio State and you have a low vision service, they are likely to have a filter set that you can borrow. If you do not, then it might be a good idea just to get some of the most common colors that you might utilize. I've listed them below. Those are the ones that we used most commonly for performance and for some ocular conditions. And so you can demo those with patients to see what color they prefer, and then you can compare the saturation levels. Like I said, if you have an in-office tinting kit, it's really easy to do it that way. If you're working with a lab, you can tell them, hey, we're looking at brown. This is the saturation level I had, but I'm wondering if we could get like a 30%, 20%, 10% to compare, and they can normally help you out with that. So next case here, TN, is a 52-year-old Caucasian male. No real pertinent medical history for him. As far as his ocular history, he has both optic atrophy and a cone dystrophy. Just a little bit about him. He's a teacher and he likes to boat in his free time. That's really key. He gets a lot of glare and light sensitivity when he's out on the water, which he does almost every weekend. So he was really motivated to try something to increase his contrast and decrease his light sensitivity that he has secondary to his ocular conditions. He was already pretty successful with corneal gas permeable lenses. As you can see, he's a pretty high myope. His best corrected vision was 2100 with those, and that's really the best he sees kind of all across the board with any kind of contacts and glasses. That's just his best visual potential that he has. Like I said, his goals were to address glare and the light sensitivity complaints, make it a little easier to play on his boat, and also just to correct his vision. He really didn't want to be dependent on glasses, which, looking at that prescription, not surprising. So we ended up choosing a contour sphere for him. Same as the other people, we just put on a clear diagnostic lens to decide on our base curve and OAD. He wanted it pretty much across the iris, so we made a 10-5 iris tint. And then with some filters that we had, we decided on an 8-minute tint for him in red. Pretty same power to what he had in the corneal lenses and identical visual acuity. He doesn't wear these all the time, but on the weekends, he's always wearing these. Anytime he's on the boat, going to sporting events, he really appreciates the contrast that he gets, improved contrast in colors, as well as the decrease in light sensitivity. AR is a 19-year-old Caucasian female who came to my office wearing sunglasses indoors, which is what she does pretty much 24/7. She has a very long-standing problem with migraines, 1 to 3 to 5 a week, every day, every other day. And light is a very strong trigger for her. So she wears very dark, wrappable sunglasses, even inside. She wears hats when she's outside to kind of double up on the light protection. No real pertinent ocular history. And you can see from her medications that she's trying pretty much everything she can to manage her migraines. Some oral medications as well as Botox injections, and she's still experiencing these 2 to 3 times a week, every week. Currently, she wears a low prescription in glasses. She sees 20/20, like I said, no major ocular history. Her goals were to address the glare and the light sensitivity. She was really hoping to decrease the triggers that she was experiencing from all the light sensitivity she had. So this is a perfect patient for a tinted contact lens. So we ended up ordering an Alden transparent lens. They have a series of these transparent tinted lenses in various shades of walnut. She ended up liking walnut number 3. And we chose our base curve and overall diameter based on some lenses that we trialed on office. And Plano power because she was still planning to wear her glasses, and then her prescription sunglasses when she was outside. She no longer needed to have tinted glasses indoors, and that was really her main goal, was to decrease the amount of time that she needed to be wearing those. She did have a little bit of a decrease in the frequency of her migraines and much, much improved with her light sensitivity complaints. So our last kind of colored option is a pupil occlusion option. I talked a little bit about that with the painted and with the printed versions. The indications for this are going to be patients that don't have usable vision and maybe have a scar or opacification within their pupil. Patients that have intractable double vision, so diplopia that just does not go away. Patients that have leukocoria, so maybe they have something in the back part of their eye, like a scar or some tumor or surgical procedure, where the pupil is always white and they're self-conscious about that, maybe just in photos or in person. Also, not used super commonly, but amblyopia treatment as well. So we think about patients being patched if they're undergoing amblyopia treatment. This is basically like a patch you just wear on your cornea. So as you can see from the pictures, we have the options of pupil occlusion with and without surrounding color. Like I said, for the printed and for the painted versions, you can do clear or occluded pupil, but you could also do occluded pupil with a clear surround. So that would be appropriate for your amblyopia treatment. Or maybe a patient whose iris appears normal, but they have leukocoria, or they have, like I said, double vision or some other issues with light sensitivity, and they just want to black it out, but they don't want to wear a patch. So the fitting process, I talked a little bit about that, but for most of these patients, we're just using whatever clear diagnostic lenses we have from our regular spherical fits. So we'll just take something that's in a low power, especially if we're not worrying about a power for the lens, and we'll just look at the same things we look for our normal patients. We're looking for centration and coverage. We're looking at the movement of the lens, and then we're asking the patient about the comfort. A lot of the times you don't have a lot of specification as far as the materials. Some of the labs have 1, maybe 3 options, but you do have more options as far as base curve and OAD. So you can try to get the fit most comfortable if you can change some of those parameters. Depending on what lab you use and what type of lens you're ordering, they might ask for some more specific parameters from you, like your HVID, what is the pupil size? They might specify they want light, dark, inside, outside. Keratometry values might be required from them, as well as refractive error if you're trying to correct that with your lens. Some of them have the options for that, some of them don't. So I would check with your manufacturer to see what specific data they're interested in getting from you so that you can prepare everything when the patient comes in for their initial fitting. Lens care is going to vary by manufacturer and vary by lens material and what type of colored lens you're using. A lot of the lenses do fine with just a regular multi-purpose solution. If you have a lens that has a biannual or an annual replacement, some of the labs will recommend a periodic enzymatic cleaner, and some of them will even send their specific recommended ones to you when you get the lens for your patient. Hydrogen peroxide may be contraindicated. For some lenses, it can help leach out some of the tint, so you'll want to check with your manufacturer for that. You just want to make sure that you are talking to your patient about appropriate care so that their lenses can stay as nice and colored as the first day they got them and last for as long as you're hoping that they will for the patient, and just to minimize fading. So a little bit more about migraine headache, like our patient AR. As you might be familiar, this is a neurological disorder. It's much different from just your regular tension headaches. These patients also are typically very nauseated, and they have sensory disturbances, which is where we come in. Photophobia, photosensitivity is common, very common, 80 to 90% of patients that suffer from migraines. Some of the patients, this is a trigger for them. So like with AR, if she's somewhere, in Target or at her school and she has bright fluorescent light, that can trigger a migraine for her. Other patients, it's just a symptom, so then this might be less appropriate for them. And then for other patients, it might be during and between attacks. So if you have a patient like ours where this is a trigger, the tint may definitely be helpful for them to improve their quality of life and lessen the frequency of their migraines. So traumatic brain injury is another appropriate time to talk about these lenses with patients. The most common symptom for patients who have had a concussion is post-traumatic headache with accompanying photophobia. So these patients are also very light sensitive. They often do well with amber, blue, and brown tints. But again, like I said before, it's very patient dependent. So you just have to trial a few different things and see what's most comfortable for your patient. Commonly, these patients will also have binocular vision dysfunction. About 60% of them will have some kind of vision abnormality. We commonly see convergence insufficiency and vertical deviation or vertical double vision with these patients. Vision therapy may be appropriate for them, and also prism. And we can come in with prism. So that might be one indication. Like I said, diplopia following a post-concussive event or binocular vision disorder. If we look to the diagram, you can see just the regular way that we stabilize our astigmatic soft lenses. All the way to the left is the prism ballast version. And we're basically capitalizing on this type of lens that we already have. So if we want a soft lens, we can do vertical prism in the base down direction, which is just what we're already doing to stabilize our toric lenses. As far as rigid lenses, for a corneal lens, same kind of thing. We use those sometimes in our toric and even some of our multifocal patients. We can do vertical prism base down for those patients as well. We can get a little bit more fancy with scleral lenses. There are some scleral manufacturers that can also incorporate horizontal prism. Now that a lot of our sclerals come with toric peripheral curves, we get better stability, and so then we're able to incorporate prism in the horizontal diameter, especially for patients who are wearing a lens that's come from a molding process. So that's something to talk to your manufacturer about to see if that's an option. They don't go super high, but some of them max out around 4 or 5 prism diopters in the horizontal direction. So that might be enough for your patient to meet their needs. So moving on to a prism patient, patient KM was a 68-year-old Caucasian female. Her history was pertinent for a motor vehicle accident. And so she had vertical diplopia following this motor vehicle accident. She was doing pretty well with split prism in her glasses. You can see that she has base down and base up split between the eyes. She also had a progressive addition lens. So she was interested in managing her diplopia as well as her refractive error with contact lenses. We said, yeah, we got you. We can do that. So we ordered specialized custom toric lenses for her. We did a monovision style because the lab was like, I can't give you a multifocal and prism in a specific lens. And she was perfectly happy with that. So we did base down prism in her left eye, and she was very successful and happy with that setup. Achromatopsia, you might not all be familiar with. It's a hereditary non-progressive vision disorder. It is pretty rare. These patients have either completely absent or altered color vision. They also have decreased visual acuity, visual potential. They have a lot of light sensitivity, and they also may present with nystagmus, which we'll talk about a little bit later. These patients have a loss of either all or some of their cone photoreception function. And so if they have none at all, then they are called achromatops or achromatopsia. If they have some functioning, then they are dyschromatopsia. This can be acquired or congenital. Most often the ones that I've seen have been congenital patients.
Custom stable lenses change lives. They're intuitive, they're powerful, and anyone can fit them. It's time to simplify.
So if you look at the visible light spectrum diagram, you can see that red has pretty low energy as far as our lights, and these patients do very well with this. It allows them to get more contrast, and it decreases the light sensitivity that they get with just their normal day-to-day life, not even bright lights. If they do have some cones that are functioning, if they have some blue cones, they're called blue cone monochromats or dyschromats, and they do okay with magenta. So if you add a little bit more blue to capitalize on those still functioning cones, those patients can do well with that tint. There's also some talk about amber, brown, or gray, and those might be a little bit better from a cosmesis standpoint instead of having bright red lenses. But like I said before, that's just kind of a case-by-case basis for your patient. And if I have a patient with achromatopsia, red is generally the first one that I'll choose to show them. So speaking of that, this patient VR is a 21-year-old Black male who presented to the clinic complaining of headaches and some associated eye strain. Ocular history was pertinent for achromatopsia, and he also had congenital nystagmus. His current correction, just a pair of glasses, a little bit of hyperopia and astigmatism. His best corrected acuity was 20/190 on a Bailey-Lovie chart with appropriate illumination. And his main goals were just to address his glare and his light sensitivity. He was still planning to wear his glasses, but he wanted to cut down on some of that light sensitivity he had. We showed him a couple different tints, and he was most comfortable with a magenta tint shown here. And so we ordered the Orion Biomed for him, 8.6 base curve, 14.5 diameter, and then the tint diameter was about 7 millimeters. And like I said, the magenta tint was the most comfortable for him. So this tells me he might still have some functioning blue cones. These were Plano Power because like I said, he still wanted to wear his glasses over top. And sometimes that is a good recommendation, especially if you have patients with low vision. They might need to be wearing some impact resistant lenses over top of their contact lenses, just from a protection standpoint. Some other color vision disorders under the umbrella of dichromacy, we have protanopia, deuteranopia, and tritanopia. You can determine which your patient has with some color tests in office, and they may do well with contact lenses that filter out certain wavelengths of light. It doesn't allow them to see all the colors. It just allows them to have more contrast in some of the colors that they may not appreciate all the way. So you've seen people with the X-chrome glasses and other color vision glasses. This is just a similar idea where we filter out some of the wavelengths to allow those patients to get better contrast. Another appropriate time for using specialty lenses would be with ocular surface disease. So this is commonly used in our practice with dry eye patients, whether it's evaporative or aqueous deficient, or even if they have the diagnosis of Sjogren's syndrome, we have some patients that do scleral lenses. If you have a patient with ocular graft versus host disease following a bone marrow transplant, a patient with Stevens-Johnson syndrome, or patients with limbal stem cell deficiency, which is pictured over here, those are some appropriate conditions to recommend a scleral lens. Additionally, you might have a patient with exposure keratopathy. They may be post-stroke, post-surgical, maybe they have Bell's palsy, or just something atypical about their eyelid positioning, which causes their front surface to be open to the environment, and then they get staining and irritation and keratopathy over time. Those patients can do well with a scleral lens as well. Another thing would be for neurotrophic keratopathy. So a patient that has a non-healing but non-infectious corneal ulcer, also we call this a persistent epithelial defect, those patients can do well with sclerals too. One thing that's going to make those a little bit more unique is the addition of preservative-free antibiotics. So you really want to be careful with those PED patients that you're monitoring them very closely. Typically, you're going to see them every day because a lot of those patients will wear their lenses 24 hours a day and really just take them out to briefly disinfect, clean, and refill the bowl. But that's not something that you just let them go for a couple weeks. That would be something where you're seeing that patient every day. They have your on-call number, you're watching them closely, and also providing coverage with a preservative-free antibiotic. So some additional considerations if you're deciding to use scleral lenses for ocular surface disease is the size of your lens. So a lot of practitioners that do this commonly typically fit really large and really loose. So you want to make sure you're covering as much of the ocular surface as you can. So you don't want these little teeny tiny diameters. You're trying to cover the full cornea, the limbus, and some of the conj to get the most lubrication that you can. Preservative-free saline. So you really want to be careful what you're talking to your patient about as far as filling the bowl. These patients already have inflamed and angry eyes, corneas that are ripe for infection. So you want to make sure they understand preservative-free only, unless you're adding something, like I said, the preservative-free antibiotic. Some of these patients may have a thicker preservative-free drop, like Celluvisc or something like that. Other patients may be using, like some other kind of tears that they got from their ophthalmologist or something. So you want to make sure you're being really careful with what they're putting in the bowl and how they're taking care of their lenses. Additionally, when you're selecting your lens material and your surface treatments, you want to make sure that you have a high DK material. Some of those patients do really well with a polyethylene glycol coating that increases the lubricity and the wetting of the surface. So some things to think about. And then, like I said, really close monitoring, because these patients who have corneas that are all torn up and already angry and inflamed, you don't want to just let them go for a while, especially if you're having them wear it therapeutically. You want to be following them pretty closely to make sure they don't have an opportunistic infection. So nystagmus, which we briefly talked about with achromatopsia, is an involuntary, rapid, repetitive eye movement. There's some literature out there that supports using corneal GP lenses for these patients to improve their visual outcome, improve the contrast sensitivity, as well as decrease some of the motor indices of nystagmus, meaning the frequency and the magnitude of the eye movements that you see. There are a couple theories behind that. So the optical theory tells us that, instead of just passing through your visual axis in the glasses, the contact lens is going to move with the eye. So you're more likely to stay in the optical center. So as you're testing acuity, you're always looking through the correction instead of just getting it every once in a while. The other theory is about the tactile and proprioceptive nature of these. They think that maybe because you're getting some kind of feedback between the cornea and the eyelids and lid margins, that's causing this feedback loop to kind of dampen the motor reflex. And I've seen this with patients that they do a little bit better, especially kiddos, with a corneal GP than they do in their glasses. It is a little bit more of a challenging fit. You can't really get a keratometry value. The insertion and removal training is a little bit trickier too, but they can do it. I've had little kids do this and be really successful with these. So as long as they're motivated, you have a nice patient technician or yourself that's teaching them, they can be very successful. And like I said, get even better outcomes than they would from their glasses. So in conclusion, we have a lot of different colored contact options for patients with different ocular abnormalities, with color deficiency problems, with light sensitivity associated with migraines or TBI, or even medications they might be on, that can help improve their quality of life and their self-esteem. Like you saw with my little guy, he was just thrilled, so happy, so eager to meet new friends with his new contact lens. We also have the ability to add prism with our soft and our corneal GP, like I said, in the vertical direction. But now that we have more customization with toric, peripheral curves, and sclerals, we can sometimes incorporate horizontal as well. And then, like I said, corneal gas permeable lenses may improve visual outcome and dampen the motor response in patients with nystagmus. And then finally, scleral contact lenses can be an appropriate treatment option for patients with dry eye and ocular surface disease. I really hope that you give this a try and that you have this as an option for your patients, because it can be very rewarding and make your patients so thrilled, improve their quality of life and their confidence. If this is something you're interested in getting started with, I would reach out to some of the specialty labs that you work with to see what kind of options they have, what kind of specialization and parameter specifications you have, and also what kind of information, what data do they need from you to get started, so that you're setting yourself up for success and you're ready to fit the next patient that walks in your door requesting the service of you. Thank you all for your time. I hope you're all staying safe and healthy wherever you are. These are my references, and then these are some of my image references. Can't take credit for all of those. Stay well.